housekeeping things. I'm from Jersey, so I feel like we have the best bagels, but these bagels were pretty damn good today. So congratulations on that. Secondly, there's like some good times and bad times to give a keynote speech. Good is like at the beginning of the conference. The worst is like the last presentation of a multi-day conference. Somewhere in the middle is right after lunch. So if you got to take a nap, that's fine. Just don't snore too much and distract your neighbor. So I'm Mike Litterer. I am very used to presenting on peer recovery supports for people who have no actual clue what peer recovery supports truly mean. So I'm really excited to present to a room full of people who have dedicated their lives to this, dedicated the last 3 days to learning about this. So I'm gonna change it a little bit. They said I needed a PowerPoint, but I gotta be honest, I'm really not a good PowerPoint follower. I'm more of a storyteller, so I will do my best, especially for the audience at home, to stick with the PowerPoint, but we're gonna do our best. And we're already starting with the clicker not working. All right, so we're gonna keep it there and just keep talking because the clicker's not working. So I read a book, Presentations for Dummies, and they say when you do a good presentation, you start with a story. So I'll start with a story. Raise your hand if you've heard the upstream public health story before. Has anyone heard that story before? All right, so just a few. So here's the quick version of it. Husband and wife work their whole lives with this dream of retiring to live in a cabin in the woods by a stream. They work their whole lives and they make it happen. They retire, they buy a cabin, they move out to the woods and they live by a stream. And they decide every day in the afternoon, they're gonna go take a nice, slow, relaxing walk along the stream. Well, they do this for a few days, and one day they're walking, and all of a sudden they look and they see this little kid floating down the river. The husband's like, oh, okay, I'm gonna jump in and oh, perfect, thank you. I'm gonna jump in and get the kid. It's really cold. You better run back to town and get an ambulance and whatever else. So they do it. They go in, they save the kid from the water, everything's fine. Next day, they're walking down the river. Now there's 2 kids in the stream. Now the wife's like, all right, well, you were in yesterday, so I'll jump in, I'll get the kids, you go get the ambulance, whatever else. Every day they're walking by the river, more and more kids. So what do? They say, you know what? It's crazy that we're getting wet every time. Let's get ropes and let's get a hook. And instead of having to jump in the water, we're gonna hook this kid and pull him out, right? Then they're like, okay, well, that's not working. So you know what? Let's put in nets. Let's put nets across this stream so as the kid's floating down the stream, we'll be able to catch them. And they're doing all this stuff. And then they convince the town to move an ambulance station right down by the stream. And they do all these things. And someone stops and says, wait a minute. We're spending all this money. We're spending all this time. We keep on getting wet. Kids are in the river. Has anyone figured out why these kids are in the river in the first place? And what someone does is they walk upstream and they realize that on one side of the river is a school and the other side is a playground. And in between is a bridge that's broken. And as the kids are walking across, they're falling in. The idea of upstream public health is we have to do our best to go upstream to fix the bridge. We need to do everything we can to stop the kids from falling in the stream in the first place, right? But do you think that's perfect? Do you think we're gonna stop every kid from falling into the stream? No. So that's the story that's told. Let me see, okay. Where am I at? I'm gonna tell you the new version. So this public health story, upstream story, has been told for years and years and years. I mean, a long time. But what's the one thing that this story assumes, right? The story assumes that every kid wants to be and is ready to be pulled out of the river. It assumes that this kid wasn't just there swimming. It assumes this kid wasn't just floating down the river having a good time. Or it decides that this kid, of course wants to come out, right? Well, if we compare this story to substance use disorder, and we talk about individuals with substance use disorder, we all know, being in the field, is everybody immediately ready for help? Is everybody ready to just stop today and totally change everything? So there's a lot of people out there who are sort of, in the moment, okay with being in the stream, right? But what we know, and sometimes what they don't know, is the stream could get dangerous. There's rapids, there's deep holes. Some people in the stream don't know how to swim. So our job is, yes, we need prevention activities to go upstream and fix that bridge so the kids don't fall in. That's not going to be perfect. We need to have resources and services that are going to pull people out of the stream and bring them to safety in the most effective, efficient way. But we also need to be able to support the people who are in the stream and are not ready to come out yet. So I encourage and I describe the role of a peer recovery specialist as sort of all of those things, right? Working to fix the bridge, working to pull the person out of the stream, but most importantly, and especially when you infuse harm reduction into that public health story, serving as a lifeguard, a swim instructor, I don't know, a life vest, what are those, swimmies, the floaties, whatever it is, because sometimes our job is to just keep that person safe while they're in the river for when they do become ready to come out. So that's the story. I've now checked off a big box on presentation for dummies, and let's move on. So my job has been, so I started in the field of prevention I guess it's about 10 or 11 years ago. I helped start New Jersey's first public recovery high school. Really great work, really got me excited, and honestly sort of pulled me out of the prevention world and sucked me into the recovery world. So I did that for a while, and then about 9 years ago, I had the fortunate opportunity to go work for RWJ-Barnabas Health, which is one of the largest healthcare systems in New Jersey, where we, at the time in 2016 and 17, worked with the state of New Jersey to develop the ORP program, which is the Opioid Overdose Recovery Program, with this idea that when an individual was Narcan reversed and brought to the hospital, that we would deploy per diem recovery specialists to go bedside and have a conversation. I can go into a long version of the evolution of this program, but I really want to highlight and not really talk about our program specifically and the one that we built, because I will say we were very fortunate along the way with some right place, right time in terms of funding and support from the system. But the most important thing I want to do today is share with you some of the challenges, some of the mistakes that we made. So while you are either in your role as a recovery specialist, advocating for recovery specialists to expand into other areas like the hospital, we learned a lot of lessons. And one of the first lessons was people thought, okay, this person was just naloxone reversed, they just died. They're obviously going to wake up and say, oh, that's the last time I'm doing that. No. They had two questions. Am I getting arrested, and when am I getting out of here, right? So we introduced this idea that when this happens, you need to pick up the phone, call us, and we would send a per diem recovery specialist, someone who lived outside, was not a full-time employee of the system, and go and intervene with this person bedside. Flaw number one, it required someone to stop what they were doing and pick up the phone. That does not work in the emergency department. The emergency department is like a casino. There's no windows, they pump oxygen in, you don't know if it's day, night, Tuesday, Wednesday. So that was issue number one. At the time, we had a team of about 12 per diem recovery specialists covering 6 hospitals. RWJ-Barnabas is a 14-hospital healthcare system. About a year into the program, we met with the state and we said to them, can we ask you a question? Why do we have to wait for someone to die to give them service? And they're like, what do you mean? They're like, well, we're not allowed to serve anyone unless they've been Narcan reversed, right? So do we wait for someone to have a heart attack before we give them blood pressure medication? No. How stupid is this? The other thing is, and this was the biggest lesson we learned, until we are fully integrated into the care team and we live within that care team 24/7, same as a nurse does, a medical assistant, a doctor, we will always be an afterthought and we will always be known as a visitor. So we convinced the state, Governor Chris Christie was governor at the time, he committed $100 million to the opioid epidemic. We were fortunate enough to get about $12 million. And we went from serving 720 patients a year with 12 per diem recovery specialists up to about 23,000 patients per year with now a full team of 130 full-time recovery specialists. So every RWJ Barnabas Health Hospital is covered with teams of either 6, 7, or 8 full-time recovery specialists, 24 hours a day, 7 days a week. This was great, right? And again, I'm already going out of order, but you know what's that movie, Field of Dreams? If you build it, they will come? No, it doesn't work like that. And I'll give you a few examples why. Good movie, and I'm a huge baseball fan, but they don't always come when you build it. We had to realize a few things, and one of those is we had to help healthcare understand how similar we were, right? Even though we have a different history, and I'll get into that. And one of the first doctors that we spoke to said, you know, you're talking about this harm reduction thing, it sounds like the Hippocratic Oath. Hippocratic Oath being like the #1 rule for doctors in medicine, the do no harm idea. That opened our eyes at the very beginning to say, instead of us speaking our language to them, let's find a way to have shared language and shared conversations. So that's sort of a theme through this talk. So let's stay there for a second. The other thing is, and we all know, stigma is real. It's real in a real bad way, right? And we saw this. I always tell the story. Our first ever deployment of a per diem recovery specialist, the guy who I still know very well, really loud, outspoken construction guy from Staten Island. You hear him from a mile away. He was on our first deployment. He happened to be at his cousin's wedding when he gets the phone call, right? So he flies down to the hospital and he shows up in a suit. And he goes, and listen, at this point, we don't even know who to talk to, where to go. And so he goes to the nurse's station and says, my name's Eric, I'm here from the ORP program. She's like, who? Oh, you're the overdose guy? Oh, okay. She's like, well, you got a real winner in the corner over there. So Eric starts walking away. And again, if anyone knew Eric, he has never kept his mouth shut a day in his entire life. So he takes like 2 steps. He's like, I can't. So he turns around and he goes, you know, I just want to let you know, not too long ago, I was that winner in the corner. And she looks at him in a suit and is like, you? He's like, oh no, you're right. I wasn't like him. When I was here, I was handcuffed, hands and feet to the bed, and there was 2 cops standing next to the bed. And I was cursing and spitting. What we realized is, right there, is what side of substance use disorder do healthcare see? The worst side, the most acute side, right? They don't see someone who's 10 years in recovery, living a super healthy, thriving life, come into the emergency department and say, hey, you know what? I have substance use disorder. You want to talk about it? No. They're getting people in who are in the throes of their addiction. They never see the good side. The other thing is that we realized is everyone is impacted by substance use disorder, right? So nurses and doctors are people. We don't know what their lives at home are. We don't know if they had a family member with substance use disorder. We don't know if they had a parent or what their experience is. And lastly, and I think really the most important thing is, the emergency department is built like an assembly line. The easiest thing for an emergency department to deal with is a broken leg. You come in, doc, my leg hurts. They send you for an x-ray. very clearly visually see your bone is broken. They say, Mike, your leg is broken. Here's a temporary cast. Go see an orthopedist. Goodbye. I hope to never see you again, right? Super smooth, super clean, super definitive. Is that how substance use disorder works in the emergency department? No. Person comes in withdrawal. Most doctors initially think they have food poisoning or some sort of GI issue. The patient is deathly afraid of telling the doctor what's going on. These are very complex patients, but they slow down, they interrupt, and they break the assembly line. So for an ED provider who is very busy, there's a waiting room full of patients, what do you think they think when they see someone with substance use disorder? Now again, sometimes they think bad things, stigma. Sometimes it brings back trauma from their family or whoever else. But at the end of the day, it's like, here we go. This patient's gonna be here forever. I'm gonna work on all this stuff. I'm gonna do all these things, and then they're just gonna be back next week. It feels like I'm wasting their time. So one of the things that we started looking into is what is stigma? What is just, I think, poorly of individuals with substance use disorder? 2, what is trauma that they're experiencing because of substance use disorder? And this is bringing back up. But 3 is how much of this is frustration? Because people, listen, doctors, nurses, any one of us, most of us can do things that are a lot easier for more money than help people, right? You know, there's much easier professions. We all do this for a reason because we want to help people. We don't do it for the money, we do it for the moral collateral that it provides us. That is the same for an ED provider. They want to help people. When you tie their hands and don't give them the tools to help people, it frustrates them and it comes out as stigma. So one of the things that we started with the conversation is, and I gotta be mindful of time, I'm very bad with time. I know I only have till 4:30, so I really gotta hurry up. Tom didn't even throw me a look on that one. One of the things that we had to do was to say, and again, that shared language, bring everybody onto an even playing field. Patients have been conditioned to hide their substance use disorder due to stigma and fear. But providers have also been conditioned to ignore it and avoid it because it frustrates them. They don't know what to do to help. So again, that theme of bringing whatever conversation, if this is recovery supports in the criminal justice system, recovery supports in healthcare, recovery supports on the moon, maybe one day, who knows? All these things, we need to bring our language together so we're not talking 2 separate languages. But it's really, really, really hard. It's really hard. And this is one of the things that boggles my mind, frustrates me, angers me, whatever adjectives you want to put in. Over the course of our history, and let's just use the last 100 years as an example, right? While healthcare was inventing insulin and penicillin and making, hospitals more comfortable and all this other stuff, how were we treating substance use disorder? We were shaving people's heads, telling them to sweep the sunshine off the sidewalk, thinking we have to punish them and beat them down to get them better. Total, complete antithesis and opposite. And for some reason and somehow, even though we've identified substance use disorder as a chronic condition for decades and decades, possibly centuries, for some reason we thought it was a good idea to entirely build the system of care outside of traditional healthcare. You could go to the hospital for anything. Diabetes, heart disease, broken foot, whatever else. But if you got something wrong with your mental health or your substance use disorder, you better go find somewhere else. It makes no sense whatsoever. And so now we're trying to fix 100 years of mistakes and trying to integrate things together. I will tell you, if we were racing and it was recovery supports versus healthcare, recovery supports is winning by far, and I'm going to give a few examples why. But I think we still need to be mindful of a really, really tough history that we are trying to overcome, especially when we are looking to work with healthcare even more. And even as recently as the waiver, which is another thing that I cannot even imagine what someone was thinking, that in the same time that we could prescribe as many opioid painkillers as we wanted to with no training, you needed 8 hours of this, a DEA registration, and I know it's gone. I know the waiver is gone, but I'm telling you, I've had conversations as recently as 2 weeks ago where there are still doctors out there who don't realize that the waiver is gone, the Data 2000 waiver. They still don't understand. So again, we have a lot to overcome. We have to take a true public health approach, but I'm going to skip. The other thing is, and just because of time, the other big piece is that we don't have, we all know this, but we don't have a healthcare system. We have a sick care system. We have a system that's built on you get sick, come to me, I'll try to fix you, and I'll make a ton of money while I do it. But not much of, hey, let's see how we can keep you healthy, keep you safe, not ever have you come to the hospital. And listen, what do you think is more profitable? Someone who sits in an 8-week course on how to eat better for their diabetes, or someone who spends 2 months in the hospital because they're having kidney failure and an amputation? There's something wrong here, right? But that is not how we in recovery supports operate. We're operating a little bit differently. I think they have a lot to learn. So this is, if you remember any slide from today, especially when you're having a conversation with healthcare, it's this. And I hope you've all seen it before. If not, remember it and use it. Research is clear. Only about 20% of a person's health is dependent on the clinical care that they are given. Only 20%. 80% is on other things like their socioeconomic factors, their physical environment, and their behavior. If you had to guess, where do you think recovery supports lives more? The 20% or the 80%? The 80%. Where do you think a hospital currently lives? The 20%. So just, you know what I think, what is it, like the KISS model, keep it simple, stupid? I think sometimes we just have to take a step back and say to ourselves like, we're trying to keep people healthy, we're trying to get them better. Should we invest more money in the 80% stuff or the 20% stuff, right? It's common sense. We understand. Now, the other thing I want to bring in, which again, I might be a little bit out of order, while substance use treatment was trying to figure these things out, like Synanon and again, all these different things, and trying desperately to convince healthcare and a hospital system to embrace them and bring behavioral health into the fold, what has also been happening for, I'm not good at math, but since the 1940s, often at kitchen tables and church basements, peer supports, the 12-step model. We have had something that's been addressing substance use disorder for 80 plus years. And I will say, and I don't have very clear definitive research or science, you might have had another presenter this week say this, but I think peer supports is 4 or 5 times more effective than almost any other previously indicated treatment, especially when they're done separately. Now, I think you should do everything together, but that's besides the thing. We have been doing what works for a long time, but how have we been doing it? Anonymously, right? We've been doing it in an unstructured way, friend to friend. We've been doing it in a way where there's been no data collection. We've been doing it in a way where there's been no documentation. So someone who's been a part of it knows, if you know, you know. But when you go to a hospital and say, hey, listen, Why wouldn't you let us bring in peer supports? It's a service that's been offered for the last 80 years. It's probably helped more people enter and maintain recovery than anything else that's ever been tried. And they say, prove it, right? Prove it. What's your KPIs? What's your this? That's hard to do. So again, we need to bring that together, but we need to focus on this because they clearly understand that end, which I think I skipped over. What they do understand a little bit more are community health workers. One of the other things that we realized is that you can easily consider a recovery specialist as a specialized community health worker. When you look at the definition of community health worker, you can literally swap the words out and almost have the same definition. So the role of peer in healthcare, let me just check out. I'm actually okay on time. The role of peers in healthcare. I'm not going to talk about what a peer does, because like I said in the beginning, I mean, raise your hand if you don't know what a peer is or what they do. Nobody, right? So I'm not going to spend time. But there are really, really key differences of the role of a peer within healthcare, and especially within a hospital system, that really, really needs to be pointed out. So first, one of the things that we had, so what we did at our healthcare system was we put together a super high-level task force called the Tackling Addiction Task Force. Now, the other thing too, and really sort of how I got connected here, is the Barnabas Health System is merging with Rutgers. So about 2 years, I had the fortunate opportunity to start to get to know Dr. Danielle Dick, who I know has been involved down here very much. And so we started working together and doing research, but she joined a task force that we had put in place in 2017. And it was all of our chiefs and captains, right? Our chief operating officer, our chief medical officer, our chief nursing officer, whoever it was, all of our chiefs, and it had everything. Security, IT, rev cycle, marketing, all this met once a month and spent an hour and a half talking about nothing but substance use disorder. And in one of those meetings, the head of our emergency department, who was absolutely one of our main champions from the beginning, said, listen, you got to realize that as an ED provider, I'm like the captain of the ship, right? Sort of like the anesthesiologist is in a OR. I'm in charge of that patient. But do you think the captain of the ship knows how to fix the engine? No. That's why we have engineers and people who can do that. He goes, that's why the most utilized, the area of the hospital that utilizes consultations the most is the emergency department, because the ED physician doesn't know everything. So when someone comes in and it's a broken leg, as clear as that is, they call an ortho consult. When someone comes in with a heart attack or high blood pressure, they call cardiology. The key thing he said was, if you can get your peer recovery program to be seen and trusted as a consult service, that is when you will win. And it made sense, right? We, as people who work in recovery every day, we look through the lens of recovery. But when an ED doctor may not see that. So when he said this, we started looking and saying, when are doctors seeing substance use disorder but not acting on it, right? So one of the things we looked at was negative GI tests. And what we realized was countless patients were coming to the ED, and what were they doing? They were shivering, they were sweating, their stomach was upset, they couldn't stop going to the bathroom. Again, a doctor could say, oh, Mike, he has food poisoning, right? Or he could say, oh, Mike might have an obstructed bowel. So what we found was all these patients coming in with these symptoms, who again, because of stigma and fear and conditioning, weren't saying, oh, doc, I have a 10-bag-a-day heroin addiction, I'm withdrawing, and I need help. No, they're just like, make me feel better, right? And what we found was we were sending patients for all these unnecessary, expensive GI-related tests. And if they had seen a recovery specialist, the recovery specialist might have said, hey, doc, I don't know. I think that person might be in withdrawal. Totally change the direction of the care of that patient, right? So we point them in the right direction. The other thing is that, and again, this takes time, but once they trusted us as a consult, we actually had to train our recovery specialists to be okay with, one, having a doctor ask them what their opinion was, but two, how to very politely and respectfully debate a doctor in a case conference. Because again, they're the captains, but we're the experts. So really the goal is to be as a consultant. See, I'm skipping around. The other thing was, in the early days, everyone was debating, okay, our peer recovery specialists in the emergency department, what color scrubs are we gonna make them wear? Because I don't know if you know, but in the ED, at least in New Jersey, every role has a different color, right? So, okay, so what color? So someone's like, oh wait, you guys do that recovery month in September and it's purple, right? You guys wanna be purple? Like team purple? Yeah. And we're like, we wanna be nothing. They're like, what do you mean? They're like, we're not wearing scrubs. They're like, everyone wears scrubs. Even housekeeping wears scrubs. We're like, and that's the exact problem. They're like, well, what are you gonna wear? I don't know, jeans and a t-shirt? Like, this was boggling their minds. Like, what are you even talking about? And what we said was listen, we get it, right? Person on your left, my right, she seems like a really nice doctor or nurse. She seems friendly, right? But for someone who has had years of horrible experience in the healthcare system, who have been stigmatized and judged and treated poorly and called the winner in the corner, are you gonna walk in and say, oh, you look like a friendly enough person, I'm gonna tell you everything? No, it's stupid to even think that. So if we walk in like a traditional clinical role, it's not gonna work. So we made the rule, no scrubs, no clipboards, nothing. You walk in as a friend and peer first. The other thing is, our first interaction with every patient has nothing to do with an intake or an assessment. We ask 3 questions. How you doing today? Are you cold? Do you want a blanket? Are you hungry or thirsty? We got sandwiches and juice. That's it. And then you walk out. You do not do anything else. You don't say, what is your name? What is your substance of choice? You know, did your mom do drugs? Like, no. You ask them if they're hungry or they're cold. Because how do you treat someone when you bring them to your house? If I invite Tom over to my house, am I saying, what's your social security number? What's your pant size? How much do you weigh? What do you make a year? No, I say, welcome to my home. Would you like something to drink? Sit down. Let me show. Keep it simple, stupid. We can't overthink these things. So we need that non-clinical. Spoke about this. The other thing is, someone said, well, why do you think peers work so much? And it was an interesting question, but we went back to our team. We had an amazing team, by the way, who, again, without any of the entire team, it would not have been possible. But we go back and say, like, what do they mean by why do peers work so much? And for us, we're like, well, first off, I don't care who you are or what you got going on. We turn to the people around us for help, right? Like the first time I had to change my tire, I called my father and said, hey, Dad, how do you change a tire? 1, because I trusted him. 2, because I knew he changed the tire before. And 3, I knew he'd patiently teach me how to do it, right? We do this in almost all areas of our life. The other thing is that, and especially why I think for substance use disorder, addiction is a disease of isolation. It is a disease of isolation. And if we haven't proven that, especially now going through COVID and the pandemic and the aftermath of all of that, we know that a lot of people with substance use disorder just don't want to be alone. But they don't want to be judged. So like I started with the earlier story in the stream, they don't want, yes, they want people around them, but they don't only want people who are only there to rip them out of the river with a hook, a net, and a rope against their will. Sometimes they want people around them who are going to float down the river with them, who are not going to tell them that they're stupid for staying in the river. They're not going to tell them that if you stay in that river, you're going to die and you should feel horrible. Like, we're not doing that. Sometimes they want to be with people who are not enabling. Again, there's like, fine lines in some of this with ethics and boundaries and whatever else. We're not talking about enabling, but again, it is a disease of isolation. And when a peer person who understands what they would have benefited from while they were in that exact position comes, they just know. Listen, I talked to Eric, who I mentioned earlier. He was a construction worker, right? He has his GED, never did really much of high school, let alone college. He has no clinical background. He is not a psychiatrist, a psychologist, whatever else. But that guy is one of the smartest people I've ever met. He just knows when you need a phone call, when you just need to be left alone, when you just want to hang and not talk. Like, this dude's got a sixth sense about him. And again, that is where that lived experience and that shared experience comes from. So, peers. We know what peers do for the patients, but what do they do overall? They reduce stigma. And how do they reduce stigma? Because they show the medical staff that recovery is possible. The recovery specialist in the hospital is not just there to serve the patient, it is to show that doctor, yeah, everyone with substance use disorder you've seen has been cursing, screaming, spitting, yelling, lying, and trying to get out. But then there's me, who has a family and a job and can prove that recovery is possible. Peers in healthcare show the other side, the beautiful side of recovery. I tell this other story. I was in a meeting and maybe as you could tell, I was getting a little passionate in the meeting, debating and whatever else. And I was arguing a little bit, right? Like, that was sort of my job. I'm an advocate, that's my job. We leave the meeting and someone who I knew pretty well professionally, but whatever. They're like, okay, we get it. We get your point, whatever else. But don't bullshit me. If your kid, so I have two boys, if your older son brought a girl home who was in recovery and said they were getting married, you wouldn't be happy, right? I'm like, not happy? I'd be thrilled. He's like, yeah, right. He goes, but why? I'm like, because people in recovery are the healthiest, strongest people in the world, right? Because most people ignore their problems. Most people feel depressed, sad, and they just go about their day and ignore it. Someone in recovery has overcome an incredibly difficult chronic condition and decided to work on themselves day in and day out to be the best version of themselves and maintain their recovery. I think everybody needs a little dose of that because we'd be a much better place. This was a person that we worked with for years who saw the beautiful side of recovery, but still after that still said, yeah, but you won't want your kids marrying somebody. I'd be like, I would be honored. I'm telling you, I just hired a contractor to work in my house who I basically decided to use them because they employ people in recovery. Because I think the people in recovery are going to show up more consistently, work harder, be more dedicated than the guy who's like, oh, it's raining out, I'm staying home. So again, it's just changing that. But they reduce their barriers, they increase engagement effectively, reduce costs by targeting focus, readmissions, and save lives. Let me check on time. Here's the issue though. The issue is that peers in the community and peers as part of NA or AA have a lot of flexibility, right? Peers can just sort of do their thing. They don't really have to follow about rules. They just use their gut and their character to guide them. Healthcare has rules. and especially, which we're going to talk about in a second, if we want to evolve to the point where we go past this being like a nice little volunteer thing to maybe a grant-funded thing to maybe a fully reimbursable, sustainable thing like nurses and doctors, there's going to be rules to follow, right? And so someone said to me once, who's better, hospital-based recovery specialists or community-based recovery specialists? And I will tell you, at the time, I thought it might have been hospital-based recovery specialists. And let me tell you why. They're living in a different world, right? They're working in the ED. It is chaos. They're in the thick of it. They got 5 people who come in within a half hour who have just overdosed. And the community-based team that we oversaw, they were working with people for over a year, right? They're meeting and having coffee. They're going to doctor's appointments together. It's like sort of just like a companion type thing. Here's the problem. The problem is there is a line between passion and professionalism. And when you cross that line and get too professional, or when you cross that line and take away too much of that flexibility, the magic is lost immediately. So when we're building these programs, and I think that one of the key issues that we haven't unlocked yet is finding that balance, finding those guardrails that keep the service within certain boundaries, within certain ethical considerations, within certain documentation and paperwork requirements that are going to be a part of billing and whatever else, but just let the peers do what the peers do well and let them bring that magic. I'll tell you, one of our first dreams was that we would go see a patient so the way our program worked, especially initially, was bedside intervention and then a minimum of 11 follow-ups for 8 weeks. The idea was that those 11 follow-ups would be like getting coffee the next day and, going to hang out at the park and going to Starbucks and whatever else. You do the math, right? When you have 120 people serving 23,000 people a year, do you think they have a minute to step outside of the hospital and go see a patient? No. They barely have enough time to make a phone call. Now, I will say the program in 2024 did almost 300,000 follow-up phone calls. So huge amounts of outreach, but are we doing the things that we really talked about? But then you have the community health worker teams who keep very low caseloads in some programs, who are able to go to doctor's appointments and visit people. So one of the things is that once you get the doors open and you get into healthcare, if you're not there already, you have to constantly take a step back and say, why do peers work? What is the magic ingredient to all of this? And is our goal or our desire to professionalize this role, to reimburse for this role? At what point are we squashing the magic, or are we diluting the magic sauce? Because I'm telling you, if you're not thinking about it, you get to that line real quick and you lose it. Then all of a sudden, you just got some knucklehead in jeans and a t-shirt bringing you a sandwich and not really doing much else. Peers need to have the ability to spread their wings and do their thing. One other quick thing is, I'm still okay. Actually, I'm okay on time. One of the other things that we realized is that the peer-to-peer model doesn't just work with peers helping other individuals. What we also realized is that we need to set up mechanisms for doctors to help doctors. And when I say doctors help doctors, I'm not talking just about like clinically, I'm talking about professionally. Really enabling, because there is huge prevalence of substance use disorder among doctors. So they need help. But the other thing was that, so our program at RWJ Barnabas, for 7 years, we had this task force where, up at the highest levels of corporate, yelling and screaming and getting people to listen. And we realized that literally almost zero of our doctors were utilizing MOUD in the emergency department. And we're like, how is that? We're serving 23,000 patients a year, and of all those patients, we had 11 BUP scripts written in a full year. Like, what is going on? What we realized is that they're in some situations, they're not gonna listen to me. I'm not a doctor, I don't even play one on TV. They will listen to other doctors. That's why the folk that presented before, they are the ones, you know who should be listening to that podcast? Every emergency room doctor there is, right? Doctors can talk to doctors just as effectively as someone with substance use disorder can talk to another individual. I myself am not lucky enough to be in recovery. And I know that even though I've spent most of my career working on recovery supports, I don't know if I could be a good recovery specialist. I've been around it a lot. I could probably fake my way through it a little bit, whatever else, but I don't think I can. I will also say that we've had great debates, and I don't know if we ever came to an answer. The program that I was at, all of our recovery specialists were in a recovery themselves for a minimum of 4 years. We didn't have family members, we didn't have lived experience. We decided only individuals in recovery themselves for a minimum of 4 years. The other thing was we had a 10-to-1 ratio. For every 10 people we interviewed, we hired one. And listen, it's a whole nother presentation what we had to do with HR and how resumes didn't matter. But when you know, you know. And we had a great team who was able to identify individuals in recovery themselves. If you build it, they will come, not always. So I said that earlier, but the other thing was, and I know I was hearing some healthcare systems in the area are doing some work to build addiction consult services. Actually, one of my clients that I'm working with now has recently engaged in a very, very robust addiction consult service that will be operated by doctors and APNs. Great, right? Bunch of doctors doing their doctor thing and the medical stuff. They brought me in and I said, well, that's great, but how are you gonna know about the people in the hospital? The only patients who are gonna get referred to this consult service are the ones who literally smack you in the face. You need to establish a culture that makes not only the patients feel comfortable about talking and addressing their substance use disorder, but also making the nurses and the MAs and the other folks in the ED comfortable to talk to someone about their substance use disorder and ask those questions. Because if not, your expensive consult service is gonna serve 10 people a month. You're gonna think it's great, but there's gonna be 1,000 people who went through your doors and never got the help that they needed. And that is why it is a program of attraction, not promotion. These programs, especially in the hospitals I've worked in, it's not about putting up a flyer. It's not about wearing purple scrubs. It's not a promotion thing. This is not an advertising issue. This is an attraction issue. It is a slow but steady, more and more people see the value, think more highly of individuals with substance use disorder, and all of a sudden, it becomes contagious to the point where we ran all recovery meetings in our hospitals, and we had, and there's a long story through the pandemic, but when we were still only in person prior to the pandemic, we had meetings with 100 people. And I bet a third of them were just staff who weren't in recovery themselves. They were just curious about this idea of like, oh wait, you guys just talk about making yourselves better and healthier and whatever else. So it's attraction, not promotion. I mentioned this, that recovery is possible. We need to expose healthcare to the beautiful, amazing, awesome side of recovery, not just the scary, sad, and bad side of it. I also say that we have had, I don't want to say long enough, but we've had, and many states have had a good amount of time and a lot of grant money to figure out, does this peer supports thing in healthcare, whatever else, does it work? I think we've established that it does. We really, really, really need to be focusing on how do we pivot away from grant funding into fee-for-service. I'll say in New Jersey, we found out a few weeks ago that we were losing $110 million in substance use related funding because of ARPA dollars and whatever else. We've also, for the last 4 years, had the opportunity to be billing Medicaid for our peer services, and almost no one was. Because why? It was a lot easier to use the grants, right? All we do is we submit our reports. Why go through all the paperwork and the care plans? Well, you know, it's going to start catching up with us. There's actually a great report. I don't know, I might actually have a slide on. Oh, here, look, see? I've been thinking about this for a while. This is a great report. If you haven't seen it, if you have any interest on the reimbursement side of peer support, SAMHSA put this together. I don't know if this gets emailed out, or you can just Google the title of it, whatever else. This is a comprehensive report that breaks down peer reimbursable services across the state. I will point out that there's definitely flaws, somewhat. In the report, it said in 2024, New Jersey billed for peer services for 256 people. That could be true. It seems low, but again, no one's really billing the way they should. Does anyone want to know what it said about Virginia? Zero. Actually, not even zero. It said 11, and because 11 is such a small number, they couldn't include it because it'd be identifiable. Now again, this is like my third time in my life being in Virginia, so I don't know if that's true or not. Could be totally false, but yeah.
So I'm the director for a SAMHSA grant in
Yeah.
Virginia, billing for peer services and emergency departments, and I found 0 health systems that are doing it. If someone is doing it, please tell me, but it's mostly CSBs and other programs.
Yeah, so listen, the SAMHSA report came from CMS. So they're coming from the billing system, so there is a chance that it's pretty accurate. But listen, as these grants go away, listen, we're in uncertain times right now, especially with grant funding. We need to have sustainability. I'll take questions in 2 seconds. I just want to make sure. Oh, say that again?
Could you repeat the comment? Microphone, because we could not hear it.
Oh,
I can do it when.
yeah. So Virginia has only billed for 11 people, according to the past report. And again, I would go to the report and read the data, but again, very much lower. Anyone in the room in the prevention side of things? Does anyone work in the prevention field? Okay, so a few. One of the key tenets of prevention services is coalitions, right? I worked on coalitions my entire career. Group of key stakeholders, multidisciplinary, task force people that come together to serve community problems. Hospitals and healthcare are communities within themselves. The coalition model that works everywhere else works equally, if not better, in healthcare. You need the right people around the table and work on this together as a team and take that coalition approach, especially because, which here, and I have twofold in here, hospitals are trying to solve how they're addressing the other 80% of people through technology. Some of it might work, some of it won't, but they're trying to do it with technology when I feel, and again, this is my own soapbox, but I would say, look at what our peer recovery specialists are doing. We're doing exactly what you're talking about. You're trying to buy technology to do what we are already doing. Yes, our hands are tied in that we can only do it for individuals with substance use disorder, but learn from us, replicate us for other conditions, which is why they ultimately replicated the community health worker workflow after our peer recovery specialists. The other piece is that the other piece of frustration that it took us a while to figure out, doctors didn't like that they were responsible for the care of an individual when they got the time, the faith, whatever it was, to trust that they would call a peer recovery specialist in to provide care to that individual, that once they handed that patient off, poof, it's like they went up in smoke or went into a black hole. It is essential that if we are going to provide peer supports in the hospital setting, we need to document within the health record. Again, not crazy, extensive clinical care plans, but just put in the progress notes what happened with that individual. Because one, that makes the doctor feel more comfortable to call for a peer consultation, but two, they become more aware of all the great work that the peer does, not just referred to peer recovery and then ... end of story. So it's essential. And what is this going to do? Peer supports have a long legacy, but not a long paper trail. We need to do better about documenting peer support and capturing how effective it is, capturing why it's one of the best interventions there is. Now, again, we've done a lot to do that, so I'm not saying that we haven't, but we still have a long way to go. And I'm pretty good. The last thing is that we have to also remind ourselves, hospitals do really want to help people. I know they're a business. I mean, there's billion-dollar healthcare systems. I get it, right? But at the end of the day, of all the healthcare systems I've worked with, none don't have the right intentions. They really want to help people. There's just a huge gap between their intentions and their actions. I believe for substance use disorder, peer supports especially. Now again, I didn't focus on the medical side, the addiction consult side. You have those presentations by others. I believe just like going upstream, fixing that bridge so the kids don't fall in the river, I think recovery supports, especially within healthcare, can serve as a bridge between intention and action and help healthcare systems do what they need to do. Because they have a wrong pocket problem. They're spending a ton of money on patients with substance use disorder and not in the right places. You need champions. We need to have shared success, shared data, shared language. SBIRT, I won't go into just because of time, but I will say SBIRT's not going to work unless there's an effective resource for that provider to refer to, which is, again, access to peer support in the ambulatory care setting. The other piece is we have to keep driving towards self-assessment. We don't want nurses walking in and saying, when's the last time you did drugs? When's the last time you did That's not going to work. We need to get these tools into people's hands so they can be screening themselves, not feeling stigmatized. And then we need to make sure the doctor or the nurse, when they get the results of that self-assessment, have an easy, accessible way to go get that person connected to peer supports. The other thing too, and this is just what I'm learning about, and I encourage you to read, there's a lot of stuff coming out about using AI screening tools to identify patients with substance use disorder. I'll be honest, I'm a big AI fan. I think there's a lot that can be done with it. But I think this is going to be really interesting because after you solve all of this, you still got to go back to the first problem of if you build it, they will come. If you don't know the patient's there, you don't know who to provide service to. We need to do a better job in identifying patients with substance use disorder so we can not only intervene effectively, but early. And again, let's be the 80%. Let's keep doing our 80% thing. Let's show healthcare how 80% is done, and we'll be ahead of the curve. And stay hopeful. It's very uncertain times. I'm actually leaving now to get on a call about funding that we thought we lost that might be coming back and all this crazy stuff that's going to happen and whatever else. But you know what? And I said this, our president had a brother with substance use disorder who he talks about all the time. The vice president's mother is in recovery and very open about it. And RFK, the head of human services, is in recovery himself. We have key leaders that know recovery. Maybe an antiquated model of it, but they know recovery. We need to leverage that and advocate because we can't just sit here and be cranky for 3.5 years. So, and that's it. Thank you.
Let's give another round of applause to Michael. Thank you so much for your wonderful talk. I'm going to give the microphone really quick to the person whose comment folks couldn't hear.
So sorry about that. So My name's Natalie Miller-Moore. I'm a project director for a SAMHSA grant in the state of Virginia. And I am going to be doing a webinar about billing for peer services, but I have yet to find a hospital system billing in Virginia. Per the report, which I just double checked, very few people are doing so. The CSBs are doing it, and some other groups are doing it, but I'm basically confirming what Michael was saying, is that we're still working our way through this, and I agree that grant funding or bundled care may be what's being used instead, but that is not as sustainable as figuring out how to do it. And thanks to the people who've been helping me along the way.
Yes.
Thank you so much for the local and important information. I know we're at time, so we do not have time for questions. And so if you do have questions or want to follow up with Michael, I don't know how much time you have, but please feel free to email.
I can stay for about 10, 15 minutes, and that's my email. I'm more than happy to talk, email, whatever.
Yeah, so those that are virtual, feel free to reach out via email, and thank you all so much. Take care.
Thank you.